5, 4, 3. There you go.
Good afternoon, everyone. I'm Maan Malahfji from the Houston Methodist Hospital, and welcome back to MMI conference. Today we're going to talk about aortic regurgitation, and I'm going to cover echocardiography as well as cardiac MRI. So I have no competing interests and no one competing with me for the hour, so I'll cover as much as I can. And we'll go over mechanisms of AR, we'll show some patient examples in between, and we'll cover the echocardiographic evaluation of severity, as well as related remodeling and how that can guide management. We'll focus on MRI and recent findings with outcome studies relating to MRI as well as echo. So to cover some of the aortic valve complex, if you notice, the aortic valve leaflet insertion point corresponds to the aortic annulus, and this is kind of what's called a virtual ring at the insertion of all of the three leaflets. And there's a couple other components here that are very important when it comes to aortic regurgitation. So there's the sinotubular junction, and then there's the annulus itself, and then there's this anatomic junction that's actually between the ventricle and the aorta. And abnormalities of all of these, or in combination, or in separate, can be leading to the development of aortic insufficiency. When it comes to listing mechanisms, there's long lists that you can kind of go back for review in multiple sources and review articles. But a big area of focus is trying to divide if there's a leaflet abnormality versus an abnormality of the aortic root complex or the aortic root annulus complex. You can obviously have multiple mechanisms, and in reality, we see a lot of patients who have multiple causes for AR that are occurring in the same patient. So if you think about primary leaflet abnormalities, there's congenital disease, and common ones are bicuspid valve and the less common quadricuspid and unicuspid valve. In older individuals, we see degenerative disease of the aortic valve leaflets, thickening calcifications that can lead to malcoaptation between the aortic valve leaflets. Myxomatous degeneration and leaflet damage due to subaortic stenosis are less common causes, but ones that you have to watch out for. And infection and inflammation of the aortic valve is one that you also don't want to miss, where you can get bacterial endocarditis or merantic endocarditis. Rheumatic heart disease and radiation-related disease are less common, and iatrogenic causes are less common, but we see those every once in a while. When it comes to the aorta abnormalities, you have dilation that can be at the annulus level, the SCJ level, or the actual sinuses, or a combination of. And all of these will lead usually to aortic insufficiency that's predominantly central. Degenerative disease that can affect the aorta and affect aortic compliance. And then inflammatory and genetic aortic syndromes are less common, but ones that you don't want to miss either. Dissection is one of those scenarios that can lead to AR using multiple mechanisms, and we'll go over example cases that cover this. This is kind of the analogy of the Carpentier classification discussing aortic regurg mechanisms, and then you have type 1 and type 2 and type 3. Type 1 is relating to normal cusp motion, but with aortic dilation, or much less common is cusp perforation. And you notice here when it comes to dilation, you can have isolated root dilation at the sinuses, you can have dilation at the SCJ level as well as the ascending aorta and the root, and then you can have predominantly ascending dilation, and all of these can really predispose you to developing aortic insufficiency. Type 2 is the cusp prolapse. This is more common in folks with bicuspid valves and injury to the aortic valve. And then cusp restriction is what we see predominantly in older individuals, as well as those with rheumatic heart disease and radiation-related disease. So here's an example of bacterial endocarditis, a 64-year-old man, weight loss, dyspnea, abdominal pain, and you immediately notice a lesion that's attached to the ventricular surface of the right coronary cusp. And you see associated AR. So whenever you see AR, usually even at mild degrees, there's usually an abnormality. It's a little bit different than seeing mild TR or mild MR in otherwise healthy individual. There's usually a cause. And when you see those leaflet abnormalities with focal areas of thickening associated with AR, you have to take into account the clinical context, of course, but it should immediately raise suspicion for infection. So you see the vegetation on the aortic valve, and then you see this lesion on the mitral valve also, with kind of an aneurysm formation, and you can immediately tell that there's significant mitral and aortic valve disease without even the color. Notice the severe LV dilation with EF of 62, and then you see on TE the vegetation associated with a significant convergence zone here at the aortic valve, as well as perforation in the anterior leaflet, as well as central MR, and this patient obviously had to have surgery. Now notice when you look at the short axis of the aortic valve, I want you to kind of keep this in mind. When you have these either prolapse lesions or eccentric lesions with damage at the edge of the leaflet rather than central AR, if your either TTE or TE plane cuts through this section, for example, you won't see the jet as well as you would if you create a section through where the regurgitation is. And this is where doing a sweep in short axis and long axis, again, whether it's TTE or TE, using your X-plane is really important to actually identifying the regurgitant jet and its course. Here's another example. 51-year-old he had a murmur that was heard by his PCP, no symptoms, and you see a huge aortic aneurysm with central aortic regurgitation, and you see an aortic dissection at the level of the STJ. Notice that there's virtually no STJ left with effacement, and this was like closer to 9 centimeters. And you see the central jet, but notice that it also extends actually in between the coaptation zones. And the question here is what has caused the aortic regurgitation. So with dissections, you can have sort of an immediate or pre-existing dilation of the ascending aorta that will usually actually get provoked in the acute phase of dissection, and that can cause AR in of itself, even if the dissection doesn't extend down to the aortic root and the valve. You can obviously have extension of the dissection down to the valve that can disrupt leaflet closure, and you can get to a point where you can have tears of the leaflets, obviously with severe dissections. So in this case, you see the large convergence zone, and here it's not really, very difficult to determine that this is hemodynamically significant aortic disease. So there's no dissection extension to the leaflets intraoperatively, but actually they saw significant fenestrations in the left, in the non and the left coronary cusp, as well as a dilated annulus. So there's essentially leaflet disease, there's annular dilation, and obviously ascending aortic dilation. This is a patient with history of rheumatic heart disease, and you see the mitral stenosis, you see the commissural fusion in between the leaflets and the thickening of the leaflets, and obviously you have restriction of leaflet opening as well as coaptation with central aortic regurg, and then you see significant concomitant aortic stenosis as well. One thing to keep in mind is, with very severe AR cases, you will have a high transvalvular aortic velocity that can be up to 3.5, 3.7, even up to 4 meters per second. So you may not necessarily have concomitant aortic stenosis, but you have an increase in the TVI at the LVOT level, and your continuity equation assessed aortic valve area will still be, relevant in terms of deciding if there is concomitant AS with AR or not. But in reality, the mean gradient and the pressure load that the LV is exposed to is really what primarily drives the outcome. So if you have significant AR, with or without concomitant AS, you can really use the gradient to guide your management, even if your aortic valve area, for example, is 1.2 or 1.3. So this is a continuation of this patient, radiation heart disease. Notice the restricted leaflet opening with mitral and aortic regurgitation. And here's 3D showing also the restriction of opening and the central coaptation defect. Here's an example of a bicuspid valve, and you see the eccentric jet. Notice that the Ascending aorta is also relatively dilated. The SCJ is effaced. And when you look on short axis, you see the fusion between those two coronary cusps, as well as the aortic insufficiency, that here we may not be at the level of the orifice convergence zone, but you see that the aortic regurg is also not purely central, but also along that coaptation zone between the fused leaflets and the non-fused leaflet. Here's an extreme example of leaflet prolapse as well, with severe concomitant AR as well. Now let's talk about echo grading. So one of the key parameters is the width of the jet. And we'll go over some of the advantages and the pitfalls of all of these, and the guidelines really illustrate all of these parameters very nicely. So in terms of acquisition, you want to get a long axis view as well as a zoomed image, optimizing for the vena contracta as well as the jet width. And generally we measure it in the LVOT within 1 centimeter of the vena contracta. One thing to keep in mind is if you try to kind of look at this parameter from apical views, you see very often overestimation of the jet width because of entrainment of flow and because you're in the far field, and multiple other parameters can lead you to overestimate AR severity, particularly if the farther into the LV that you go. So it's a simple and sensitive screen. You can very often identify mild central AR and keep going, but in terms of its estimation of severity, particularly identifying moderate from severe, etc., it can have limitations. In cases with eccentric jets, you can have significant underestimation, and then as the jet expands below the orifice, particularly on those apical views, don't let those kind of misguide you into calling a lot of folks with mild AR into moderate or moderate to severe. And obviously the size of the LVOT, since you're using this as a percentage, is going to affect this. So here's an example. So here's an example of mild AR, which you can tell even without me playing this. But in scenarios like this, where you have a highly eccentric jet, you don't want to let this misguide you into underestimating AR severity. Here's another example that is unfortunately not playing. Let me see. Okay, my station on this side got stuck now. I'm going to restart this on here. Okay, and here's that eccentric jet, which for whatever reason is not playing very well. Man, this was fine just 5 minutes ago. Okay, I'm very good at describing things, but the images say many, many more words. Let me. It keeps getting stuck. PI at the LVOT level that will clue you into this being a high flow state. And this was an example where the personal long axis shows the jet, but it was very brief, and because of shadowing calcification from the aortic leaflets, you don't see the jet width very well. So it could have been easily led someone to call it mild AR, but when you look at the other ancillary findings, this was actually closer to moderate to severe aortic regurgitation. When it comes to the vena contracta, it's very similar to the jet width in terms of you want to try to ideally get it from the peristernal long axis in a zoomed view, and ideally you want to measure it where the jet is actually perpendicular to the insonation beam of the ultrasound. As you get into those apical views or highly eccentric jets, the vena contracta can actually overestimate the AR severity, and it becomes a little bit problematic. So it is still usable in eccentric jets. It is independent of flow and the driving pressure, and it's a very good marker to try to measure the regurgitant orifice size. As I mentioned, multiple jets, bicuspid valves where the jet is extremely eccentric, it becomes difficult. You ideally want to measure it where you can see the convergence zone, so the three components of the jet, the zone is the vena contracta and the jet area. And ideally, when you measure it from these peristernal long views, you get the most reproducible measure. It is a little bit less reproducible compared to identification of regurg volume and fraction by MRI, and it is still pretty decent variability though. Jet area and the short axis view, it's sort of ancillary or equivalent to the jet width, but in short axis. Same thing, you want to actually do a sweep across the aortic valve in short axis, and you don't want to be misled by the distal portion of the jet where it becomes turbulent flow, and increased momentum and entrainment of flow can make the jet appear much larger. When it comes to the PISA measurement, so you're using flow estimation at the convergence zone by shifting the Nyquist limit, and you create hemispheres of flow as the jet accelerates towards the regurgitant orifice, and you're using the conservation of mass principle to essentially solve for the flow through the regurgitant orifice being equivalent to the flow at the hemisphere. So you use the hemisphere area, 2 pi r squared, and then the aliasing velocity that you'll have to shift in the direction of the jet. And you solve that equation to get the EROA, and you have to obviously get the peak AR velocity from the continuous wave Doppler across the aortic valve. The challenge is in multiple areas. So one is getting a nice hemisphere variability throughout the diastolic furion period of the radius. Getting this peak velocity is also sometimes challenging in highly eccentric jets and incomplete envelopes. And the variability in this estimation, unfortunately, is still pretty high when you compare it to more reproducible measures. And on the other end, it is decently validated with prognostic outcome data. So it is very good to measure in AR, but in reality, in real-world practice, it is less feasible than mitral regurgitation. The other aspect is obviously eccentric jets, as it is with mitral regurg, and trying to get it from the apical views can be challenging. What I would take away the most from this is if you see a convergence zone without even shifting the baseline, you have to recognize that there's meaningful AR in this patient. So here's an example. This patient has a prolapse of this non-coronary cusp with a very wide vena contracta. You see the PISA formation without even shifting the baseline. And then you shift the baseline and you measure the radius at 0.7, and you get a regurgitant orifice area of 0.3. And you can also do 3D to try to get the 3D vena contracta area. And in this patient, we had done a 3D color Doppler at the aortic valve, and you can manipulate, post hoc on the actual software to get the vena contracta area, which, in this case, you get 0.7, although the 2D one was 0.3, and that kind of tells you how this has challenges and limitations in using these parameters. Pulse wave Doppler in the descending aorta, this is a hallmark of aortic regurgitation and all the physical signs of AR that we've always learned about. It is a simple and supportive sign of severe AR, much more specific if you see holodiastolic flow reversal in the abdominal aorta. You can get it from TTE and TE, but it has limitations in the way that it's also reliant on the compliance and the sensibility of the aorta as well as the LV-EDP. And it has multiple other causes that can contribute to this, less commonly such as ruptured sinus valsalva or AV fistulas. And then obviously in acute AR, you may not have completely holodiastolic flow reversal. A brief reversal, particularly in younger individuals, is also normal. The density of the jet also has limitations, and you want to kind of take it as a supportive qualitative parameter rather than rely on this to grade AR. Similarly, for pressure half-time, we'll have examples that get into this, but with very steep deceleration time and pressure half-time of AR, it is suggestive of significant AR, but it could also be modulated by diastolic dysfunction and pre-existing LV compliance issues. If you have very long pressure half-time, it's quite supportive for AR being not significant. When it comes to quantitation, so we rely on the LVOT flow, comparing it to the mitral flow, and here you measure the LVOT diameter, and you get the DVI at the aortic valve. You measure the mitral annulus diameter, and the difference between them can give you the regurgitant volume. You divide that by the LVOT flow, and you get the regurgitant fraction. You can compare that against your 2D LV volumes to make sure your numbers are reasonable. It has challenges, particularly when it comes to measuring the mitral valve annulus area, particularly if there's calcifications, and if the Doppler, the pulse wave Doppler is not done at the true annulus, it can also have miscalculations that lead to this. You can also compare the LVOT flow to the RVOT flow, and in this example done with TE, you get an RVOT stroke volume of 47 versus an LVOT of 120, and you end up with a regurgitant volume of 73 mLs. So this is what the most recent guidelines kind of walk us through. You rely on your vena contracta, the jet width, and the ERO primarily for quantitative parameters, and then these qualitative Doppler parameters are ones that you kind of put together. And when you have multiple parameters that are specific for hemodynamically significant AR, particularly if you have multiple of them, you could potentially be done, essentially. If you have a flail leaflet, a wide vena contracta, a wide jet, large conversions don't even before you move your Nyquist limit, and then significant whole diastolic flow reversal, you can essentially take these to the bank that this is significant AR. You should still aim to quantify particularly the LV volumes and size, because not everyone with severe AR will need surgery immediately, right? And you rely on, for the most part, same parameters to grade mild AR, and then when you're in between, you want to try to quantitate primarily with those 2D Doppler methods that I alluded to and the ERO. We looked most recently at folks who had a same-day echo and MRI that included the spectrum of AR severity. And there's still, discrepancies, but if you systematically go through the echo and you quantitate it to the full extent, if you will, the exact concordance is pretty good. So 64% exact grading, and then within one grade is 95% between echo and MRI. It's really very few cases that had major discrepancy between the echo and the MRI severity. But, these parameters that I showed you earlier, some of them are essentially much more reliable than others. So what we found was the vena contracta width, 0.3 for mild and 0.6 for severe, the jet width, and then more importantly, the LV size, particularly when those with preserved LV function. These are kind of the top parameters you want to rely on to either rule in or rule out significant AR. The flow conversions and the pressure half-time methods were a little bit less reliable, and I'll get into some of those details. When it comes to actual quantitation of regurg volume between echo and MRI, you notice that the outcome plot shows that there's decent variability, but there's no systematic underestimation or overestimation by echo relative to MRI. But the limits of agreement are pretty sizable, about 35 mLs, and that's really the same for 2D Doppler quantitations, either the mitral annulus or the LVOT versus RVOT, compared to PISA. But notice that the PISA feasibility was much lower. So in this patient cohort, the feasibility of doing PISA in these, very often advanced cases with highly eccentric jets, which is where you need it the most, was only in the 30s, essentially. When you kind of go through these parameters, we notice that using LV-EDV, essentially a surrogate of pressure and volume overload leading to significant remodeling of the left ventricle, and vena contracta have very good performance to detecting severe AR by CMR with high specificity. And then the end diastolic flow reversal, or essentially whole diastolic flow reversal in the aorta, is quite specific but significantly less sensitive. And when it comes to the quantitation parameters, they're kind of in the 40s for the most part when it comes to LVOT versus mitral annulus and LVOT versus RVOT. And if you add these together, you can essentially improve your AUC for detecting significant AR. So, for example, adding 1 plus 5, so a sizable vena contracta with an enlarged ventricle, it can give you a very high confidence for detecting severe AR. Adding a large vena contracta with a wide jet and an enlarged ventricle with preserved function, you can essentially take these kind of cases to the bank that this is severe AR. So this is kind of where we may be in the future. So you kind of start off similarly, where you look at specific and accurate criteria for mild AR and then specific and accurate criteria for severe AR. But now you're going to give a higher weight for the vena contracta width, for the jet width, and then more importantly also for the LV volumes. That's kind of the newer addition. The other thresholds are overall similar. And then specific but less accurate parameters for severe AR are the flow reversal, the large flow conversions, and the pressure halftime. And then if you have uncertainty, the quantitation for the most part is still the same, but you want to try to get at least the LV size and then the jet parameters on color Doppler. Those will actually take you home for the vast majority of cases. So you won't necessarily have to go through the quantitation, although it's still advised for a large portion of cases. So let me show you some examples of kind of this discussion about LV volumes and discrepancy against diameters. This is a 47-year-old. You notice the highly eccentric aortic regurgitation jet with a bicuspid valve. She had reported history of pulmonary hypertension. Her LV diameters were mildly dilated, essentially, if you go by current chamber quantification guidelines. If you quantitate her AR severity, you get 3 plus AR. And then essentially, she was kind of observed, but if you actually look at her echo 6 months later, now she's in heart failure, essentially. And her LV volumes, which I didn't show you from the prior scans, were actually severely dilated. And she may have been at the time of getting surgery already, and this is the flow reversal in the abdominal aorta. So this is very common, particularly in women or older individuals, where the LV diameter, especially depending on where you measure it, are you measuring in the midsection of the LV or in the basal segments, you can really underestimate the extent of the LV remodeling that the patient has. And then you notice her LV volumes on MRI were also severely dilated, and her EF had declined already. Let's talk a little bit about MRI. So with CMR, the quantitation is a little bit different. We do these sequences called phase velocity sequences, and you're essentially going to align it just above the aortic valve, and you directly measure the velocity and by extension flow as the column of blood goes backwards at the ascending aorta. So you integrate the velocity over time, and you get the regurgitant flow, and you get the forward flow in the aorta, and you take one divided by the other to get the regurgitant fraction. This is much more reproducible in this study compared to echo grading with very wide limits on echo, but much narrower inter-observer and intra-observer variability on MRI grading. Another important aspect is serial follow-up. So this patient, for example, has moderate AR at baseline, 40 mLs with 26%, mild aorta dilation, mild LV dilation, and then you can follow them over time. In his case, notice how he has still the same AR severity, but his LV remodeling has progressively increased over time. Obviously, in other cases that you want to consider MRI is when there's uncertainty on the echo, or you have multivalvular lesions with AR and concomitant MR. And other findings on MRI that can potentially be helpful is if you have pre-existing LV fibrosis that can be related to aortic valve disease, and we found those to be associated with outcomes where people with LV fibrosis or scarring had worse outcomes, whether it's non-infarction scar or infarction-related scar, and that was independent of the extent of remodeling and LV decline in these patients. In addition, we also measure the extracellular volume fraction, and in this parameter called the index ECV, which is kind of inferring the relative expansion of the extracellular space, which can happen in advanced aortic valve disease. And this was also additive to assessing AR severity in predicting outcomes in this study. So, as I may have alluded to earlier, there's kind of an increasing interest in the AR space, and this is driven partly by percutaneous devices and development in new valve replacement strategies, but also because we're starting to recognize that this isn't an uncommon condition, and particularly within the older population, it becomes more and more prevalent, where these patients are already at high risk for intervention, and it becomes difficult to assess whether they're symptomatic or not and what the reason for their symptoms is. So if you got the old natural history studies, it was primarily much younger individuals, whereas now we're starting to see many more patients with advanced age, multiple comorbidities, and the question is, do you treat those the same way that we've treated the 30, 40-year-olds with bicuspid valve and severe dilation but no symptoms? So current guidelines tell you, you operate if there's symptoms, you operate if there's asymptomatic decline in LV function or significant remodeling. The ESD will give you, both the systolic performance as well as the extent of remodeling. And, based on those natural history studies, once it gets to more than 50, or an index value greater than 25 per meter squared, that usually relates to worse outcomes in the long run. But the question is, what is it that we need to define as severe AR? So in the current guidelines, both from the ACC and the ESC, that vena contracta threshold or regurg volume greater than 60 ml or regurg fraction greater than 50%, were considered kind of what puts you into this category, and otherwise you would be in the moderate category. But in reality, if you look at all these natural history studies, they all included really 3 to 4 plus. So it's really those 45 mLs, 46 mLs of regurg volume, 40% regurg fraction. These were in these studies actually. And this is kind of that seminal study from Dr. Bono, where you see the rate of adverse events starting to really ramp up at 50 millimeters. But more recently, probably because now we're including a larger study with a slightly different population than what was included, you notice that the rate for adverse events, both from these Mayo and Cleveland Clinic series, really starts going up when the ESD threshold gets to 2 or higher. And in this study from Belgium, that relied primarily on AV repair, the rate of adverse events in the long run in those who actually had surgery prior to developing any of these thresholds, they actually did better in the long run. So the question is, are we operating too late on these patients, and should you start considering elective intervention in the asymptomatic individual with preserved function at as a different threshold or at a different or using newer parameters? So we looked at this with MRI, and we also found that, same thing for Regurg volume and fraction, where the threshold that are associated with adverse events in asymptomatic individuals were lower than those 60 mLs and 50% Regurg fraction. And then similarly for diameters as well as volumes. And we find that essentially the LV volumes and diameters can have discrepancies. So you can have someone with an LV volume that's beyond the threshold, but an LV diameter that's under the threshold. And that's a sizable portion. So in 25% of cases, you could have an enlarged LV by volumes, but their end-systolic diameter is still normal. And when it comes to predicting adverse outcomes or events, the volumes actually outperform diameters. Similarly with echo from this Mayo series, notice also same thing, 30% will have a large ESV, but the ESD hasn't gone to that 25 threshold. And this is further outcome data on ESV and EF in asymptomatic patients, also from Mayo Clinic. And you notice that the threshold for where the hazard for adverse outcomes increases is starting towards the 60% for EF, and then for ESV is around 45. Similarly for ESD, once you're getting to 2 or higher, then the risk becomes elevated. If you incorporate all of these parameters as well as strain, you notice that there's multiple subgroups of AR where you can have one or the other, or you can have all of them. And then people who have multiple of these parameters while asymptomatic can be at a higher rate for adverse outcomes compared to those who do not have any remodeling that's at the extent of these 3 parameters. Specific scenarios to consider. So aortic regurgitation in women. This is an older study that actually showed women would have significantly worse outcomes than men, and this was including operative mortality and overall survival. They also found that the burden of symptoms was higher, and the referral for operations was essentially less commonly done than it is for men. And at the time, the generalization that you would use these unadjusted LV diameters for women, essentially many of them may have significant AR with symptoms, but they will never reach that ESD threshold of 5 or whatever. So this was still, shown even now. So this data from the Cleveland Clinic looking at older versus younger individuals as well as men versus women. You notice even when you index the LV volumes, there's still a significant difference in the extent of remodeling between men and women, and then also between older versus younger individuals, where younger individuals, which are kind of what we've always studied, will have significant LV remodeling, whereas older patients may not dilate their LV to the same extent. And if you keep waiting for the LV to get to severe dilation in some of these groups, they may get to heart failure before they reach these parameters, essentially. This is another concept to think about, what we consider moderate AR, particularly in older individuals from this study from 2008. When you look at moderate AR here in the dashed lines, they actually also had intermediate outcomes when it comes to these adverse events, which I believe included progression to AVR or AFib or heart failure, and then overall survival that we didn't see to that extent in younger individuals. So in summary, you want to define the mechanism of AR because that's really key for management, for deciding how you're going to follow this patient, if you need any additional testing such as CE, and then for surgical planning, if they have hemodynamic significant AR and they may be a candidate for aortic valve repair. Always look at the leaflets, particularly when you see any degree of AR, aortic root abnormalities or both. And then you have to still do a comprehensive assessment on TTE, but focus most on the LV size, the jet parameters such as the vena contracta and the jet width, and then look at the ancillary findings. We still see cases where it appears moderate, but you still see whole diastolic flow reversal in the abdominal aorta. So, you have to kind of put all of these together. When it comes to the acquisition, really focus on optimizing RVOT, Doppler, mitral valve Doppler. This will really help with the quantitation. Same for PISA, where you have to really work to get that hemisphere. And then when it comes to management, you have to really go by the LV response to AR. Be careful in those who are kind of considered moderate to severe or moderate but are actually symptomatic, where not some of those people may need to be operated on. And I think that's it. Sorry for the video issues. Questions? Yes.
Thank you for your time. That's great. So I have a question regarding VMR. Yeah, I have a question regarding your paper on, the LVOT minus RVOT volumetric self-assessment
Mhm.
compared to VMR.
Mhm.
It's about 55% correlation. Do you know it's overestimating or underestimating, or how?
55% correlation in terms of like grading, you mean how they're concordant? Well, that's the overall assessment. So, Roa, I think you may have met, she was our fellow at the time, and she went through all of these echoes essentially and graded them blinded. So the 55%, I think it was close to 64 actually, that was the overall grading of AR severity. Where that agreement was in that range for exact concordance, and then in excess of 90% if it's within one grade. And that's essentially calling someone moderate versus moderate to severe. That may not necessarily be meaningful. When it comes to actually the quantitation of LVOT versus RVOT flow, those actually, there's no bias here. So it doesn't over or underestimate compared to MRI Regurg volume. What the issue is that there's a widespread of variability. And Dr. Zaghabi, if you have any additional comments, please add. If you look at the Bland-Altman plot, essentially you can be off by up to 30 mLs essentially, and that's not ideal. But this was only looking at the actual quantitation. So this figure is just showing you Regurg volume. It's just showing you Regurg volume average by echo and MRI, and then the difference. It's not showing you all the other parameters. So yes, you could be off by a sizable margin, but you're still going to look at all the other findings on the echo. So if you're off by 20 mLs, that may not necessarily be a big deal, because you're still going to look at LV volume, you're going to look at vena contracta width and flow reversal. And if it's 60 versus 80, that may not necessarily be relevant to the patient. Yeah. Would you agree?
I agree. I mean, the beauty with echo is you have multiple parameters that you have to understand how to use. The beauty of echo is you have multiple parameters, but you have to understand the pros and cons of each. I think our latest publication emphasizes two things. One, if you have significant AR, chronic AR, I'm not talking about acute myocarditis and dissections, etc., but the ventricle dilates. You cannot have severe aortic regurgitation without the rotation of the ventricle. So if you tell me what are the two most important things in everything else that we have, one is color Doppler. The vena contracta, whether there's flow conversions, what's going on in the alveolar tract, and size of the vena. These are the most important. Yes, you have to learn quantitation, and yes, there's variability in quantitation, but it has to make some sense. You have to learn how to do it with some variability. The others that we talk about, and that's why the importance of is there are some specific signs, but they're not frequent. Okay? If you tell me, I'm looking for pressure half-down of 250 or 300 and below, you're going to have many patients with severe AR who may not know. It's specific, but not sensitive enough. You understand? Same thing for portal diastolic reversal in the aorta, be it in the abdomen or fever. Specific, but not sensitive enough. So the ones that balance sensitivity and specificity are color Doppler measures in addition to ventricular size. I think these are the most important things because then you're not missing too many. Otherwise, you have to quantitate more and more and more often. So that's one message. The other message is for all of us, clinicians and imagers, is that I can take some of the blame, actually, all the people who have, shared that guidelines, because we didn't have data. We treat mitral regurgitation similar to aortic regurgitation, as to quantitation of severity. What is severe? Severe, we say greater than 60 ml or greater than 50% of regurgitant fraction. And they are the same, but these two lesions are not the same at all. We demonstrated, right, that the ventricle remodels differently for the exactly same amount of regurgitation. AR is a pressure and volume load. It's not just a volume load. So, of the same amount of regurgitation, regurgitant volume or regurgitant fraction, the ventricle will remodel more and more and more compared to mitral regurgitation. The bottom line of that is what you think is currently moderate to severe may be significant. So anything with a regurgitant fraction above 40%, regurgitant volume above 50, I would consider it severe. You're going to act if patients have symptoms or have significant remodeling of the ventricle. But don't ignore it if it is somewhere in the borderline zone. You have to take a look at how does the ventricle behave to this pressure volume load situation, right? And then you weigh, repair versus replacement, age, comorbidities, many other things for you to intervene. And it's not straightforward, but I think so. The two messages I have for you: one, within echo Doppler, there are some specific signs that also are sensitive. And these are the ones that you're going to concentrate on. Two, what is called moderate to severe, current criteria may be actually on the severe side, right? So keep in mind those patients, how do they behave, how do they remodel.
Go ahead.
Thank you for the amazing presentation. I have a question regarding 3D vena contractor.
Mm-hmm.
What situations do we use it, and how reliable is it? For example, with 2D vena contractor, which is not as reliable and not
Yeah.
reproducible.
Yeah, so it's a learning curve for 3D vena contracta area. So there was a recent paper from Europe, from the Penica group, and they integrated assessment on echo with 3D TE vena contracta measures, as well as MRI and biomarkers. And essentially, there's still a quite decent variability in its estimation. And the reality is, if you only do it once every year or every blue moon, you're not going to be reproducible. So what I would say is similar to how we do 3D for every single CE that we do. If you see AR, you see MR, you should get 3D color and actually practice and continue to do it. The more reproducible we are, the more useful the parameter will be. I don't think it's ready to be used, as an alternative to the other parameters. In reality, for surface echo, the 2D vena contracta is still performing very well, and hopefully this will be validated further, as we go along. But for uncertain cases, if you don't have access to MRI, for example, or there's still uncertainty, you can still get a very good quantitation using the 3D area. Yeah. I want to show this also real quick. So this is comparing AR and MR for the same grade of severity. Notice that the LV is essentially larger for aortic regurg cases compared to mitral regurg at almost the entire spectrum of severity once you get to moderate or greater. So keep that in mind, as well as the LV hypertrophy aspect of things. Anything else?
I have a question.
Uh-huh.
For vena contracta
So for vena contracta, you don't have to. The measurement, especially if you do it on the parasternal lung, as long as you try to optimize actually showing the narrowest portion of the jet, showing the flow conversions on one side and the jet area on the other side, you don't have to adjust the Nyquist limit. In reality, actually, adjusting it may lead to overestimation because you're going to start seeing some of those red cells that are getting entrained by the jet. For PISA, you still want to adjust the Nyquist limit for essentially almost all the cases, but one thing that I would always keep in mind is if you see flow conversions without even adjusting the Nyquist limit, you can essentially also take it to the bank that this is meaningful AR. Yeah. Yeah. All right. Anything else? All right.
Thank you.
See you, Joe. Thank you.